Hi, I'm Deepak Bhatt at TCT 2013 with ongoing coverage from CardioSource, and we're going to discuss 3 exciting trials that were just presented. And here with me today are 2 superstar interventional cardiologists and good friends, Dr. Roxana Moran and Dr. Jeff Papa. So let's start off with the optimized trial. Now, Roxana, you were the chair of the DSMB. Do you want to just tell us what the design of that trial was?
Thank you, Deepak. Thank you for disclosing that I was the chair of the DSMB. It's important for our viewers to know that. But
and I should mention I was on the steering committee too in terms
That's
of disclosure.
Right. It's an important.
It's important. To do with the trial.
Well, it is important, but I think this is a very, very important trial. And although the Endeavor stent is not being used as much or at all in this country, what's really, really important and I think very much topical is this short duration versus the normal duration of dual antiplatelet therapies. As everybody knows, we're giving 12 months based on no real data, just the gestalt that we need to cover patients with DES for 12 months. This study, for the first time, not in a large numbers of patients, 3,000 patients were randomized to receive a 12-month standard of care dual antiplatelet therapy versus a 3-month dual antiplatelet therapy. And the overall endpoint was a combined endpoint of major adverse cardiac events and major bleeding, so the NACE, the net adverse clinical events. And the NACE was chosen so that we could study 3,000 patients, because if you can imagine, in the stable population, this could have been into the 10 or 20,000 patient study to actually separate the ischemic and the bleeding complications. So that's really, that was the design.
Right, and so bottom line, it was non-inferior to use 3 months versus 12 months. So that, I think, is consistent with other trials in the DS world that have shown that maybe you don't need to go 12 months. But, Jeff, what's your take with all of this?
A couple thoughts up front is that although we generally tend to put all drug-eluting stents in the same class, the phosphorylcholine coating on the Endeavor stent is a little unique, and it's felt to be antithrombotic, and we saw at this trial that the PROTECT II trial actually had a reduction in very late stent thrombosis, and I've always felt that may have been due to the intrinsic polymer. So although we're going to make general statements about drug-eluting stents in general, the Endeavor stent may have been a little bit different.
Right.
But I think the more important piece, I think there's 2 points. One is that the event rates were low. I mean, good for folks undergoing stenting now, because we have very low event rates, and that might have some statistical impact in terms of the delta that's picked for the non-inferiority. But secondly, I think the broader implication is that stenting now with the 2nd and 3rd generation stents has been viewed as safer. And when we began into the realm of 1-year and 2-year dual antiplatelet therapy, we were dealing with the 1st generation stents weren't so good with Cypher-Taxis.
Right.
So I think 2 things are really operative here. One is that the event rates are low for people. I think that's good, and that may be attributable to the next generation stents. I'm going to use this as useful information to me. I mean, in a patient who might be at high risk for bleeding or has a bleeding problem, I think the cessation early on with a drug-eluting stent at 3 months might be useful. But I think the caveats for that are going to be that the Endeavor stent may be different than the other drug-eluting stents.
Sure.
The good news is all of these stents are becoming much safer.
Right, and I think the registry data as well support that many times you can get away with a shorter duration of DAPT if you have to with 2nd generation DS. So it seems to be a consistent message, but what do you think?
It is absolutely consistent, but Deepak, for the newer stents and other stent platforms, we really do need prospective randomized trials that are well powered and are looking at that. And I'm proud to say that Abbott just announced yesterday in a press release that they are going to do exactly this with 6,000 patients randomized to 3 versus 12 months, and I'm honored to lead that study with Mitch Krukov.
And that's great, because they have a label indication in Europe for shorter duration, but I think this is actually very good to actually do the science.
Look at that.
Critically important trial, and you should have the power really to nail down the answer.
So great to see Optimize in that same direction.
Yes, very reassuring, especially from a safety perspective in terms of launching a big trial. You want at least some signal that it's not a crazy idea to do 3, and I think Optimize provides a lot of reassurance that 3 probably okay, at least in patients that aren't high risk in terms of ACS risk. Well, that's good. Let's move on to Arctic interruption. And in many respects, the theme continues. That was examining 12 months versus longer DAPT. And it was a bit hard actually enrolling patients in that trial because a lot of doctors said, I'm going to continue DAPT beyond 12 months in higher risk patients, presumably. But the investigators ultimately did complete the trial, and it didn't seem that longer was better than 12 months. So once again, a trial that didn't support a longer duration of DAPT. So what do you both think? Roxana, is that
Well, I mean, I think I want to
information?
congratulate Jill Montelesco for leading these types of very important studies, and very similar to what we're seeing in the
Right.
DAPT study when
Yes.
patients, it was difficult to randomize them at 1 year.
Right.
The same thing was found here in the Arctic interruption. And here, these were, as everyone, and I'm not sure if our viewers know, but Arctic allowed the use of PRUs and platelet function testing to actually escalate or make an important choice in the more potent agents in those patients who had high PRUs, and there was no difference using that strategy of guiding platelet function guidance therapy. And at 1 year, after 1 year, only half of the patients were randomized.
Right.
But I think the theme is there that in the stable patient population who actually passed the bleeding test and the ischemic
Right.
test after a year, if you give them an aspirin and stop that, it's going to be okay. Now, of course, we're not powered with the half of the population. We have to wait for the DAPT study of Laura Murray and Dean Kariakis, but I think the spirit is, and we're seeing this, we saw it in the Excellence study, we saw it in the Prodigy study, that maybe these long-term dual antiplatelet therapies may not be needed.
Look, going back a little bit in time in Charisma as well, in the overall trial, it didn't actually meet its primary endpoint. So at least in a broad population of non-ACS patients, it didn't seem that prolonged
So I feel like I
was
have to be the
useful.
historian here a little bit, right? So how did we get here? How did we get to the whole concept that dual antiplatelet therapy was going to be an indefinite piece? And you have to march all the way back to the fall of 2006 when we thought everything was fine with just a year of dual antiplatelet therapy, and then we saw this beast of very late stent thrombosis, which I still think now retrospectively was due to the two first-generation drug-eluting stents that we used with the polymeric coating over there, with the ciphrotaxis.
And Renu Vermani told us we were going to see that.
Well, that was a first-generation piece, right? So, but what's happened is we've now embarked upon 20,000 patient randomized trial for short versus longer duration dual antiplatelet therapy. Is now we've changed the whole script. We're dealing with different stents, different patient populations, different pieces, and so. I was always hoping that there might be a benefit based on your work from Charisma, that in these patients with very active atherosclerotic plaques requiring stenting and symptoms, that maybe the dual antiplatelet therapy would have a secondary prevention on MI. And maybe I could get Deepak to speculate a little bit about, if it's not stent thrombosis, are there any other potential atherosclerotic stabilization pieces that dual antiplatelet therapy would do? And if not, maybe we should be stopping everybody at 3 months.
Yeah, I think it's a great question, but a complex one. And to simplify, for the sake of time, I think if a patient has a history of plaque rupture, there is likely a benefit of protracted dual antiplatelet therapy. And if they haven't, and they're getting a second-generation DS, I'm not so convinced that that's there. I think the second-generation DS really are game changers in terms of stent thrombosis risk, in my opinion, better than even bare metal stents. So if one believes that, that rate of stent thrombosis gets so low, DAPT probably helps prevent even those few stent thromboses with second-generation DS, but the bleeding might overwhelm that little benefit. So, we'll see what ongoing trials show, but I'm glad that you're launching this big trial. That'll be important.
But I think I want our viewers to be cautioned to make sure that when they're looking at these trials, and that for us as investigators to be really astute about this, to make sure that when we're presenting data, that we separate stent-related events versus patient-related events. And in this milieu of a patient with multiple plaques and everything else that's going on, the comorbidities, the lipid-rich plaques that are in these patients who are not reaching goal with their medical therapies, the prolonged dual antiplatelet therapy, if we do see a benefit, should not be engaged and married to the stent, but rather to the patient.
Yeah.
Yes.
And I think that's a really, really important point for our viewers, our cardiologists, our referring physicians, and all to understand that concept very, very well.
So, Deepak, is a prior history of an acute coronary syndrome going to be sufficient, do you think, until we have better evidence to say that's the syndrome of patients that we'll be thinking about?
Let me be clear, because this is a great, though speculative conversation we're having. To the audience, I'd say, stick with the guidelines for now, which say 12 months of DAPT in ACS patients, 12 months of DAPT in DS patients, barring some bleeding problem. So obviously use good clinical sense. But yes, I think that's the real demarcating feature. If a patient's had an ACS, they've already ruptured a plaque, more likely to happen again. And I think there may be a window for protracted DAPT. But on the other hand, I think if patients haven't had an ACS, short of really complex bifurcation stenting, if it's second generation, I think you can probably get away with a shorter duration. But, there are ongoing trials and we should really wait. Well, it's been a terrific discussion. Hopefully this was of interest to all of you, a very exciting TCT.